the class. Okay. We just had someone that just joined us. Okay. All right, everyone. Well, thanks for joining me. My name is Katiuscia Gray. I am a licensed clinical social worker. All right, what's going on here? Here we go. I'm a licensed clinical social worker. In addition to that, I'm also a certified yoga teacher. I have a practice in Lynbrook. It's called Mind Meets Movement Counseling Services. So if you ever want, I'm not going to even say refer because we're all super full, as you could all imagine. We're in a mental health crisis and there's not enough therapists that look like us. So we are just in some crazy times. But for purposes of today, we're going to talk about the clinical assessment. The clinical assessment for purposes of the day consists of the BioPsychoSocial Assessment and the mental status exam. So yesterday, Amira sent out with the Zoom link the psychosocial assessment that she utilizes. In conjunction with that, she sent out the mental status exam. So I would encourage you to either print that out or take notes because we're going to be following sort of her format. Okay. All right. Okay. So what is a biopsychosocial assessment, right? A biopsychosocial assessment is a comprehensive assessment that includes an evaluation of needs and risks, right? It determines how, I call them patients. I'm pretty sure a lot of you guys call them clients. So if you hear me say patients a lot, it's just my school of thought. It's just where I came from. So patients, clients, same sort of thing, right? It determines how our patients function in the community, their history, their perception of themselves. It determines their current mental health status, and it makes us understand our patients as a whole person, right? And it really does set the tone to provide the best possible care possible to the people that we see. All right. So why is it important? Just like how I said, it gives us a comprehensive assessment of our patient, our client coming to us. The goal is not necessarily just to obtain all this information, right? It's very difficult as a new therapist. I was a new therapist way back in the days. So as a new therapist, you think that you're being intrusive. You think that you're being a little bit nosy. That's not what it is. We need to get as much information as possible so we could know who this person is, right? Okay. So the purpose of also the biopsychosocial is understanding your patient as a whole person, right? Your patient is not just their anxiety. They are not just their depression, right? This person is coming to us seeking help, right? So for example, they're coming to us seeking help because they're anxious, because they're depressed. That's what they're presenting. But I always like to say, who is this person? This person has a story, right? And it's up to us to sort of find out what this story is. They are more than their diagnosis. So when we talk about the whole person, we need to know everything. It didn't just start with anxiety. It didn't just start with depression. What is the story of this specific person sitting in front of us? Who are they and what are their stories? I'm sorry, more people are coming in. Okay. Okay. I like to, I'm sorry, it's very hard for me to focus and let people in. So if you hear me stop, my apologies. I like to say, I like to use the analogy as the whole person of they have a story, right? So chapter 1 through, I'm 45. So chapter 1 through 45, right? So we need to go back to chapter 1. Who is this person? Looking at this person as a whole person. Okay, so let's now start breaking down the psychosocial assessment. We're going to start off with the presenting problem. Why are they here? right? What makes them come to therapy? Have them describe it in their own words. Have them describe it in their own layman's word, right? So I like to say when a person comes to me, so we got this referral, and based on the referral, you said that you have anxiety. Tell me a little bit about that. Tell me what makes you seek therapy. What is their presenting problem, right? Have them, as I always say, describe it in their own words. That's super important because it gives them ownership on why they're here. During this process, it's super important to start looking for cues. We'll talk about that a little bit later. Cues include eye contact, right? Clues include how are they dressed? What are their mannerisms like, right? When they're explaining this story to you as they're here, what do they look like? Do they look like all over the place? Do they look a little disheveled? Maybe they're starting to tear up. That is all part of our clinical assessment of this person, okay? If you have any questions, just raise your hands. Let me just make sure no one else is in the waiting room. Okay. All right. So the developmental history, right? Let's talk a little bit about the developmental history. I know most of you guys see adults, right? I know I specialize in children and adolescents, but most people see adults, right? I would imagine. No one sees children, correct?
The youngest I have is 14.
Okay. So you see adolescents. Okay. But for the most part, I think she said everybody sort of sees adults or 18 and over, rather. Okay. This is still super important. So for purposes of people who see kids, the developmental history really should be received and obtained from their parent, because their parent is sitting with them on this psychosocial assessment. And going back, the psychosocial assessment is not going to be done in one session. It's a continuous thing that we're getting. We're continuously asking for information from our patients to figure out who this person is as a whole. So let's go back to developmental history, right? So the developmental history says a lot of who they are today. It impacts how they understand things currently. It captures a number of different things for us, right? What kind of child were they? Were they any developmental delays, right? Did they talk on time? Did they walk on time? Did they have any difficulties with sensitivity? I always ask sensitivity issues with textures with food. Did they have a hard time with eating? Were they a picky eater? What about when you wash their hair? When you were washing their hair, did they used to scream? Was that very sensitive for them? What about when you would hug them? Was that very sensitive for them? A lot of people have sensitivities with tags on their clothes, right? You'll hear some people say, I don't like the tags on my clothes. That is sensitivity issues. Sensitivity issues has a lot to do with occupational, right? So occupational meaning that leads us to believe. So if this child had all these sensitivity issues, I wonder if she or he had any early intervention services. So you see the buildup. So you see the story that we're trying to create and how we bring it sort of home. So then that leads us to early intervention services. Did this person have any early intervention services? Did they have occupational therapy? Did they have physical therapy? Did they have speech therapy, right? Let's know a little bit about their birth. Was it a normal birth? What is a normal delivery? Most kids who are born premature tend to have a little bit of deficits. Not all kids, but some kids. If you've had some deficits when you were a kid, it's highly likely that you probably have a little bit of deficits as you've gotten older as well. Some people show it a lot more than others, and it's our sort of job to sort of uncover that. Okay, am I making sense so far? Okay, awesome. Okay, we also want to know about developmental milestones, right? As I said earlier, we want to know how did this person, if they can't provide the information, maybe this is something that they need to go back and ask their parents. Can you tell me what kind of kid I was, right? Some people will know, some people will not. I always ask this question. Were you a highly sensitive child? Were you a highly emotional child? And I'll tell you why I asked that question. There's a huge correlation between kids who are very highly sensitive and very highly emotional has a tendency to develop anxiety later on, right? So the information for them is coming in too quickly and their brain can't process it. It's something that is genetic. Maybe it's something that they was just born with. It's just how this person is. But it is our job to kind of figure out and develop this assessment of this person. So one more time, highly sensitive kids, highly emotional kids have a tendency to develop anxiety later on. So that's a very important question to ask, because they are what I like to call pre-diagnosed. It's pre. Okay. Then we want to know a little bit about, oops, sorry. Oops. How did I get all the way over here? Sorry, what happened? Okay. Then we want to go a little bit into the family origin. Did I go too far back? No. Okay. So now we want to go a little bit into the family origin. Who did they grow up with? Did they grow up with their mother? Did they grow up with their father? Did their grandparents raise them? Any siblings, right? Who was in this household that reared them? I grew up with a very multicultural family. So my grandmother lived with us, my grandfather lived with us, my aunties lived with us. It's important to capture sort of all that information, right? Extended family members, how did the extended family members treat them? Was their parents married? Who did the discipline? Did they have family meals together? We want to know the story of their family. Was the family emotionally available for them? And how we phrased that was, tell me a little bit about your mom and dad. Were they huggers? Were they kissers? Would they say, I love you? Would they give you hugs? Did they pay attention to you when you were home? All super important questions. This is where I like to lean in, right? I like to lean in because this is a very sensitive subject for people. Most people have very traumatic relationships with their family. So it's important to start paying attention to the cues of your patients, right? So for example, if you're asking a patient, so tell me a little bit about your mom and dad. And when I say emotionally available, were they just working all the time and you kind of had to fend for yourself, or were they there? Right? It's a very sensitive subject if you're not ready to hear that. So pay attention to what they look like, right? While they're talking about this. Some people get tearied up. Some people you could tell, you can feel that this is a little awkward for them. And this is where you lean in and ask, I noticed that you blinked very rapidly. I noticed that your legs started shaking very rapidly. It's okay. We could take a pause. If you don't feel like talking about that right now, we'll put a pin in that for right now. But it is important to understand that down the line and when you're ready. Super important. Another important question. Any family history of mental illness? Why do we ask for a family of mental illness? Mental illness, just like diabetes and high blood pressure, most people have a predisposition for it, right? So if your mom has a mental health issue, if your dad has a mental health issue, if your uncle, your grandma, an auntie, if someone in the family has a mental health issue, you are predisposed for it. Right? So it's important for us to find out if there's any history of mental illness in the family, because the chances of them being predisposed to what is in the family bloodline and in the family gene is super important. Okay. Any history of sexual abuse, physical abuse. This is also a very difficult question to ask. So we have to say this with extreme sensitivity as possible. Now is the time to lean in as well with something like this. So she goes, or he, Yes, there is a history of sexual abuse. Okay, can you tell me a little bit more about that? Were you sexually abused? Yes, my uncle sexually abused me. Okay, can you tell me what age did that happen? Yes, they'll tell you the age. Was it disclosed? What happened? Was the police called? This requires extreme sensitivity because they may not be ready or they may be ready. A lot of people in our community have a difficult time talking about this because there's so many family secrets, right? There's so many people that I've saw throughout my career that has never disclosed to anybody. Or if they did disclose to a family member, they were shut down. They weren't believed. The perpetrator still lived in the home. They were required to lie. So look at this with extreme sensitivity, right? We also want to know about the perpetrator a little bit, right? So the perpetrator, is the perpetrator still in the home? Now, look at this with caution, because if we're seeing someone under 18 years old, we are mandated reporters. And we need to disclose to them that we are mandated reporters. So if they are saying that they were sexually abused and they are under the age of 18 and that perpetrator is still around or it wasn't disclosed, we have to, by law, report this. I know that's a hard thing, but by law, we have to report this. Okay. Is that a clap or is that a question?
That is the question.
Okay, all right.
The psychosocial evaluation at this juncture,
Yes.
is it advisable to get that deep into it? And this is why I said, oh my goodness. This is why I said,
It's all right.
because I look at the biopsychosocial as an accumulation of things. You know, a lot of the information that I'm gonna pull to populate the biopsychosocial is from the screening and the intake. So I'm gonna have a wealth of information there. So the way I understand the biopsychosocial, so I mean, you're teaching the course and it's something different.
Yeah.
But I look at the assessments and I look at the intake and I look at all that information. And then when I approach the biopsychosocial, you tell me whether or not I can improve or I'm on the right track. I approach it in the context of really setting into place the treatment plan and that's going to follow afterwards. So if I'm planning on saying, okay, these are the problem areas and I want that to be reflected in the biopsychosocial, then I don't know if I want to re-traumatize someone this early in the game,
right?
As opposed to, you know, developing a rapport and a relationship so that way the disclosure would be a lot more genuine and honest. What do you think about that?
So there's two parts to that question. You have to know your patient, right? Every patient is different. So that's why I said, pick up on the cues. This important is very informative for us as a therapist, because yes, you may have gotten your information on intake, but you don't know exactly what happened to this person. And based on what happened to this person, it's going to formulate your treatment plan, and it's going to be a part of your treatment, because most likely, yes, they're presenting with anxiety, but this person also has sexual trauma. And sexual trauma is probably causing the anxiety. So we need to know this information because, and it's not about going into the gritty details. So that is something that you need to gauge with your patient. But we do need to know if it happened, right? And what happened a little bit, not too much. Does that make sense? You're gonna have to gauge that.
It makes a lot of sense. I get where you're coming from. It's just that stylistically,
yes,
you know, because saying to someone, I'm a mandated reporter, so what you say out your mouth is going to determine whether or not, you know, someone in your family go to jail, I think is really, really kind of abrupt
Yeah, but we wouldn't
And I
say
don't know if that's conducive to relationship building.
can I interject? We definitely would not be saying it like that. Hey, I'm a mandated reporter, and that we would say all of that in the beginning for sure, right? So just to be clear, I want to just let you know that I am a mandated reporter. We need to have all our cards on the table with our patients. I am a mandated reporter, and this is session 1. I am a mandated reporter, right? And so, yes, this is your confidential session, but I do have to break confidentiality if you ever talk about hurting yourself or hurting someone else. I take that very seriously. And I talk about mandated reporter in terms of sexual abuse or physical abuse. So that is an important disclosure that we need to say from the first conversation in our office, or however way that you guys see your patients. Okay? So I'm going to move on. We can tailor that for the end, but I'm going to move on. Where was I? So the family origin, right? So we talked a lot about the physical abuse. We talked about a lot about the sexual abuse. Now we want to know a little bit of education about this person, right? We want to know if there was any learning deficits, right? We want to know if how did this person do in school? Were they in regular education classes? Were they in special ed education classes? If they were in special education classes, why was that? Did they have a 503 plan where they just got some supportive services? Or were they really in special education? Maybe they were in special education for ADHD. Generally, a child who has ADHD doesn't go away. It will translate into adulthood. So those are all important questions to ask, right? Any school-related issues? Tell me a little bit about school, right? Did you have any friends? Was school very difficult for you? Did you play any sports? Sports is a very team activity for people, right? I'm not saying everybody is a sports person, but sports is part of teamwork, it's part of activities, it's how you meet friends sometimes, right? So those are all important cues for us to understand if this person was functioning in school. What's the highest grade that they completed? Did they graduate from high school? What was their grades like? This is a really important area where we sort of lean in, right? Because education is really important, and education can be a very sensitive subject with people, right? So what was their grades like? I like to always say, tell me a little bit about your grades. So some people will say, well, I did okay. And I'll ask, okay, well, what does okay actually mean? They'll say, oh, I got a 95. Your average was 95. That's more than okay. That's phenomenal. That should be a little bing, bing, bing for us as a therapist. Very high grades are very high achievers. High achievers, there's a correlation between high achievers and perfectionistic people. So something you need to look into. That's something that you lean into. And I always say, so I think that it's awesome to be a very smart person. I think that it's specifically even more important to be a smart person of color. But there's another side that I look at when I hear that you got a 95 and you say, I did okay. Because a 95 is not okay. A 95 is phenomenal. And what comes to mind is this idea of perfectionism. And then I lean in. Do you know what that means? So you see how we're getting information, but we're leaning in to kind of solicit more information. And most likely when you bring that up, they will most likely relate to that. 100% relate to that. Okay. Right. So let's move on into their work history. Are they currently employed? Who employs them, right? If so, where? If they're not employed, why they're not employed? Tell us a little bit about why you're not working. We need to know if they're functioning in the world. If they're not functioning in the world, this is a big red flag for us, right? Because that leads us to believe maybe there's some depression there, maybe there's some anxiety there, maybe there's some PTSD, because If you're not employed, how are you supporting yourself? Right? Is your mom supporting yourself? Is your dad supporting you? Is your spouse supporting you? Who is actually supporting you? And if no one is supporting you, that's a big red flag. Okay, so what do you do for income? Where are you sleeping? Where do you reside? All important questions. Okay. We want to know about substance abuse, right? Any current usage, any previous, including frequency. I always like to say, listen, we're not your parents. I can't tell you what to do. I cannot tell you what to do. But I will say, if you are smoking, such as marijuana, this is a big thing going on right now with marijuana uses. We can't tell people what to do. But if you are coming to your sessions high, what are we doing? You're not going to really hear what I'm saying, and you're going to be high. So if you're high, because marijuana is a depressant, right? It clouds your vision into what's going on. When I hear people saying that they smoke marijuana, I want to know, how frequent are they smoking? How often are you smoking? Can you tell me how many times out of the week you're smoking? Can you tell me why you're smoking? A little bit of why. Maybe they don't know why. And that is something that we need to lean a little bit into a little bit more. Right? And so once we start asking about marijuana use, I can't tell you guys how to run your sessions, but I always say, if you are going to be in this session, you need to be physically present and you need to be emotionally present. And you can't do that if you are high. Right? Okay. Any questions about that so far? I know that could be a bit of a hot topic. Has anybody had any issues with that they'd like to share? All right, how do I go into the chat box? I don't think I could do it. Okay. All right, so we are going to move along. Okay. We want to go now into their mental history, right? Has there been any psychiatric hospitalizations, right? Maybe when you was a kid, maybe as an adult. Any suicidal ideation, any suicidal intent, any history of self-harm. A lot of adults will say to you that I have a history of cutting. I used to cut when I was whatever age, let's say 13. That is where we lean into that, right? So tell me a little bit more about the cutting. This is something that I ask quite a bit. I often say, so when we cut, it is specifically because we feel like there's an overwhelming amount of feelings going on. So self-harm and cutting is a release. So we're leaning into that a little bit more. So I always say, I have a question for you. Do you feel like things were so crazy that you needed a break? Or things were so crazy and you didn't want to be in this world anymore? Two completely different things. And that's exactly how I say it. And based on that answer, it's going to guide you into asking more questions. Because if they say they don't want to be in this world anymore, now we have to lean into that a little bit more. When's the last time that you felt like that? I know that you said that this happened at 13. But if we do not have this person, or if this person doesn't have a history of being in therapy at a young age, and they just said, oh, the feeling kind of went away. That's not true. It may be suppressed. They may get busy. They may do a lot of other things to, make sure that that feeling doesn't come back. But if we didn't learn anything about this pandemic, staying still is a very dangerous thing for a lot of people. Because that's when all the memories, you can't do anything now. You can't work, you can't go to the club, you can't party, you can't do anything. Now you have to be here alone with your thoughts. So we want to fast forward into currently. When's the last time you had that thought of self-harm? Has there been any recent self-harm attempts? Tell me a little bit about that suicidal ideation. When's the last time you felt that way? Any intent. An intent means a specific plan. If this person has a specific plan and they say, You know what, Miss Gray, when I leave out of here, I'm going to kill myself. We're mandated reporters. We have to report that. We cannot allow a person to leave our office with a specific plan in place. Now, this could be a whole other training. It's not like we're going to go, oh my God, stop. Now we're going to call the police. You have to check yourself. You have to make sure that you are emotionally regulated. You need to take a pause. Maybe you text your supervisor. Maybe you tell them to hold on for a second while you gather your thoughts so you can figure out an appropriate plan on if this person needs hospitalization, or if you can do some sort of way to calm them down. And at the end of the session, perhaps they don't need to go to the hospital. We also want to know about any psychiatric medications, right? Have they been on any psychiatric medications? Have they, at one point in their life, taken any psychiatric medications? We need to know a little bit more about that. What was the actual medication? How often they were taking it? Are they currently taking it? If they stopped, why did they stop? Lots of people will tell you, I don't like the way it made me feel. Okay. And that is something to lean into. Why didn't you like the way that it made you feel? And based on that medication, you can tell what is their history, right? Any questions so far? How we doing? This is a lot to process, and hopefully everybody's taking notes. Okay. All right. And you could just put your questions, as I said, in the chat box. And hopefully I could see the chat box. Okay. I don't know why it keeps doing that. I'm so sorry. Okay. Now we're going to go into the medical history. Any medical issues, right? The reason why we ask for medical issues is because there is a lot of underlining medical issues that has a lot to do with mental health issues. There's a huge component of people who have low vitamin D who suffers from depression. That's super important to understand. People who have thyroid issues has a huge issue with depression and anxiety, depending upon what type of thyroid issue they have, right? We want to know a little bit about when was their last physical examination. That's super important. A lot of people will tell you, oh, I haven't been to the doctor in 5 years, in 10 years, right? How can we know this person as a whole if they don't go for a complete physical? Physicals tells us a lot about what's going on, right? Especially making sure that they do their blood work. That's super important. And then moving forward, I like to say, so after you have that physical examination, make sure that you sit with your doctor and you review your blood work. You review if anything is a little bit off, because then they could report back to you. You know, the doctor did say I have a low vitamin D deficiency. And so she recommended that I take this specific medication to up it. And once it gets upped, you will start to see if they have depression with the tools and the strategies that you're giving them, they will feel a lot better. We also want to know about their sleeping habits. Sleeping habits is very, very important. A lot of people who oversleep, there's a correlation between people who oversleep and depression. There is a correlation between people who undersleep and anxiety. So we want to know a little bit about that. Tell me a little bit more about your sleeping habits. How often do you sleep? People should be sleeping at least 6 to 8 hours a day. In order for you to wake up in the morning and feel revived and refreshed, you have to have 6 to 8 hours of what I call REM sleep. And REM sleep means that your mind and your body completely shuts down. And what that means is there shouldn't be any TV on in the middle of the night, right? There shouldn't be you staring at social media in the middle of the night, right? So social media needs to be cut off. The TV needs to be cut off. Your room needs to be dimly lit because your brain is preparing itself for sleep. Your brain is going to say to yourself, oh, it's quiet. Maybe it's time for me to go to sleep. Some people have a hard time with that because if they suffer from anxiety, their mind is always racing. And if they talk about, I have a difficult time sleeping, that's where you lean in. So tell me a little bit more about that. Do you have a difficult time sleeping because of, they'll maybe say, the thoughts? Tell me a little bit more about the thoughts. Is it racing thoughts? Is it catastrophic thoughts? Tell me a little bit more about the thoughts. Maybe it's not just necessarily just the thoughts as well. Maybe also it is a little PTSD. That's something to lean into as well. Rory?
Hi, I have a quick
Hi.
question.
Did I say it right?
Yeah,
Okay.
when you mentioned 6 to 8 hours sleep, does it have
Oh, you're
to
breaking
be
up.
continuous, or could it be half 4 hours and then next? Oh, sorry, we're in the mountains.
It's okay. Can you try to repeat that? Because you was breaking up a lot.
Can you hear me okay?
Or you can put it in the chat.
Yeah. Can you put
When
it in?
you mention sleep, does it have to be continuous?
Can you put it in the chat box?
I think I heard him. He was asking the sleep. Does it have to be a continuous 8 hours, or can it be 4 hours at one point and 4 hours the next point? I think that's what he was saying.
If Rory is, if that's right, can you give us a thumbs up? Is that what you were asking? That if it needs to be continuous? Did he leave? Oh, there he is. Does it need to be continuous? Or are you saying that they could stop, wake up, and then go back to sleep again for the 4 hours? Is that what I'm understanding? I think that's what I heard, right, Kimberly?
Yeah, he put a thumbs up.
Okay, so thumbs up. Okay, so I'm gonna say no. You need a continuous amount of that REM sleep. It needs to be between 6 and 8 hours. If you wake up after 4 hours, right, your brain is going to be prepared for doing something, right? So how is it fully relaxed if we are gonna do something and then we're gonna go back to sleep? So it needs to be continuous so you can feel refreshed. You ever got not enough sleep and you wake up in the morning and you go, gosh, I am still so tired. I thought I got enough sleep, because your mind and your body really did not fully relax for you to go to sleep. That's why. I hope that answers your questions, Rory. If not, you can please put it in the chat box. Okay, awesome. We also want to know about their eating habits. Got it, thank you. We also want to know about their eating habits, right? We want to know if they're overeating. We want to know if they're undereating. Listen, I love food as much as the next one. Food is so yummy. I love food, but food is to sustain us. Food is to keep us alive. Food is not supposed to be attached to an emotion. So if we are feeling sad and we eat a piece of chocolate cake, that is something that we need to dive into more with our patients. We need to start recognizing if this patient is obese. Do they have issues with food intake? Do they have issues with not eating? As I said, food is not supposed to be attached to a feeling. It's supposed to sustain us. It's supposed to keep us alive. And that is something that we need to dive in more closer with our patients. Okay. Oops. I don't know why it keeps doing that. Okay. Any questions about that so far? Any questions about some of the things that we talked about? Anything that you want me to dive in a little bit more? I think that I forgot to mention relationships with people. That's super important too. Excuse me. Do they have a spouse? Are they dating? Do they have any children? right? Do they have any friends? Do they have any best friends? Tell me a little bit more about your relationships with people, right? This is where we can get a lot of information from people. We talk about their relationship with their significant other. It doesn't necessarily need to be a spouse. It could be a boyfriend. It could be a girlfriend. And this is where we ask, can you tell me who you date? Do you date men? Do you date women? And whatever you date is fine. We just need to know. And then I would lean in a little bit more. So tell me about your relationship. How long have you been with this partner? Tell me a little bit about not just necessarily how long have you been together. Do you feel like you could communicate with this person? Can they communicate with you? Or is it a hard time communicating in the relationship? If they say yes, there is another sign for you to dive in deeper. Most people who have difficulty communicating in the relationships have a difficulty time communicating, period, with people. It's a big indicator for you. So they may have difficulty communicating with their parents, with their family. They may have communication difficulties with working, right, with their siblings. And then there's a big correlation with people who has a difficult time communicating also has difficultiness with boundaries. So just to take a pause, do you see how we sort of kind of like created this story and starting to understand things about people with one question leading to the next question, with leading to the next, and we are getting a holistic story of this person. Okay. Any questions so far about that? Because I want to dive into the mental status exam. And why is it important that we use it? And I'm going to pull it out. So the mental status exam, right? Why we use it. I know a lot of us uses it in our intakes. I know I do because it is an important tool. The mental status exam we use this as a tool to assess current mental capacity, right? And behaviors. So that includes how is this person's attention in this session? How are they orientating? How is their mood? How is their speech? How is their affect? How is their appearance? How do they look coming to this office? Are they a little disheveled? Is their hair disheveled? Maybe they have, crumbs and stuff on their face. Maybe they have a little odor. How is their affect? Sometimes people affect are very flat, very emotionless. And that is something that we need to sort of bring to their attention, because we need to know if this is who they are, or is it the questions that we are asking that it's making them very difficult to answer. We want to know the aspects of cognition. Are they understanding what we are asking them? Sometimes it's not necessarily a cognition issue. Sometimes is they're attaining so much information from us that it could trigger them. And so we want to be mindful of not triggering them, but we also want to know a little bit about if they're able to understand us. Right? It gives us insight into our patient's psychological function. So when do we use this? We use this throughout the whole assessment. It's not like we stop at the end of intake and go, now I'm going to do our mental status exam. You're utilizing all of this and you're looking at this person throughout the whole session. So I'm going to open up the mental status exam. Oh, perfect. Thank you so much, Kimberly, for attaching that on. I appreciate that. Okay, so I'm going to open up the mental status exam. So just give me 1 second so I can find it. Okay. Okay, everybody could see that, right? Perfect. Okay, so the mental status exam, it generally looks like this. And as I said, this is something that we are going to be continuously using throughout our psychosocial assessment, right? But by the end of your psychosocial assessments, you've learned so much about this person that you're able to check this off. So you want to know about their appearance. Where do they fall under, right? Bizarre appearance, which you guys don't see those patients because I know what kind of patients you guys see. But bizarre appearance is it's 90 degrees outside and they have on a coat. That's bizarre. It's 90 degrees. You shouldn't have on a coat. We want to know about their speech. Is their speech normal? Is it pressured, right? Is it labored? And labored and tangential means if it's speedy. Maybe it's a little speedy. Maybe it's a little slow. And those are all indicators for we need to know what's going on. We need to know about their eye contact. Is it a normal eye contact? Is it a tense? Is it avoided? Maybe they're looking all over the room, right? And it's something for you to bring to their attention. We want to know about their motor activity. Is it normal? Is it restless? Is it tics? Is it slowed? We want to know about their affect, as I said. Is it full? Is it constructed, right? Is it flat? Is it labeled? A lot of times, most of our patients will have flat affects. And flat affects generally is depression, right? Maybe flat affects is a little bit of PTSD, right? We want to know about their mood. Is it euthymic? Is it fine? Is it anxious? Are they angry? Are they depressed? Are they euphoric? Are they irritable? How was their mood throughout this session? Right? We want to know a little bit about their cognition. We want to know if their orientation is impaired. We want to know if they have memory deficits. Memory deficits is a big indicator of some PTSD. A lot of people who have had tremendous PTSD, tremendous trauma, there's a part of the brain that protects them. So they literally cannot remember what happened. They think something happened to them. They have a suspicion, but they do not know because of that part of the brain, right? We want to know about their attention. Was it normal? Was it distracted, right? Maybe they kept picking up their telephone. Maybe they kept picking at their nails. Maybe they were biting their nails. We want to know a little bit about their perceptions. Was there hallucinations? Was it auditory, visuals? Now this, you guys are generally not going to see because I know what kind of patients that you guys deal with, but it's still good information for you to have as a clinician, right? We want to know about their thoughts. Was there any suicidology? Was it any intention? Was there a plan? Was it, do they have any history of self-harm like we talked about? We want to know about homicidally, right? We want to know if they are aggressive, if there's an intent, is there a plan? We want to know a little bit about their delusions. Is it grandiose? Like they're saying to us, oh, I think that I am God. God came to me and he spoke to me last night and he said that I'm supposed to do blah, blah, blah. We want to know if they're paranoid. We want to know if they are overly religious. Of course you can be religious, but are you overly religious? That is when a little red flag should come up. We want to know a little bit about their thoughts. I'm sorry, we did that. We want to know a little bit about their behavior. Were they cooperative? Were they guarded? Were they hyperactive? Were they agitated? Were they paranoid? We want to know all of this information. And then we want to close it up with, how was the insight? Was it good? Did they have good insight as to why they came here, right? Is it fair? Do they think, yeah, but I'm just coming here because, you know, my mom forced me to come. I'm just coming here because my partner said that I just get off the hook and turned up sometimes. But that's not really good insight. But it's important to continue to assess. And we want to know a little bit about their judgment. So I'm going to go back to the slides. Nope, that's not it. I'm sorry. Nope, that's not it either. Okay. All right. Okay, so we did the mental status exam. Now we're at the summary, right? So our summary of findings, right? We want to wrap all of this up, right? We want to be able to say to ourselves and this patient in front of us, okay, so based on this assessment, can I continue to see this person? This person looks like they have anxiety, and it looks like that I am the right therapist for them. So I'm going to continue to work with this person. Or maybe this person is showing some signs of bipolar, and we let our patients know our findings. So we've talked about a lot today. It seems like there's definitely some anxiety, but it also seems like there's a little bit more going on. I'm not quite sure yet until I actually sit with you. So we're going to meet a few more times, and we're going to assess if this is the right fit for you, because it's unethical and it's inappropriate for us to see people that we cannot help. We should not be practicing that way. We want to work with people that we can help. Otherwise, we are re-traumatizing them if we cannot. If you do not have any experience with bipolar, you shouldn't be seeing people who have bipolar and looking through a book to try to figure it out. Completely inappropriate and unethical. I just wanted to throw that out there. So back to the summary of findings. We want to identify the problem areas and the underlining the dynamics, and we want to explain our conclusion to our client. And then based on that, we're making a diagnosis. Then we're making a plan of care, i.e. the treatment plan. Now, towards the end of my biopsychosocial, lots of people like to do strengths, weaknesses, right? Some people say, so if you could name 2 strengths that you have, if you could name 2 weaknesses that you have pertaining to this, obviously, right? I don't necessarily like to do that. I like to talk about the 3 wishes. I say, so now that we're ending, right? We've talked about so much, and I've gotten an opportunity to know you. Tell me a little bit about if you had 3 wishes and how this would go for you. Tell me a little bit about that. You would be amazed what you get. A lot of people will say, for this anxiety to stop going away, for me to stop being mad at my mom, for me to be able to find my voice and communicate. And it is so awesome because it gives them the ownership of their treatment. And then you wrap up with saying, that was so wonderful, and we're going to get there. We're going to get there. We may not get there today, but we will get there. And thank you for sharing a little bit about who you are today. And that is the psychosocial assessment. And this is me. This is where you can find me. I'm on IG. That's my website. And that's that. I'm going to open it up. If anybody has any questions, comments, anything that I could answer. Or if you want to put it in the chat box. So Thurman, did I answer your question properly, or would you like me to, do you want to elaborate, or do you want me to elaborate a little bit more? Okay.
I have a question. This is Karen Simmons. Hi. It seems like a lot of your questions could kind of like go into an intake.
Yes.
And I was just wondering, would some of your questions, I am gonna incorporate them into my intake.
Awesome.
But for the psychosocial, would it be proper to ask some of those questions during an intake?
So I don't know how you guys do your intake. So maybe somebody can explain it to me, because for purposes from my practice, my intakes is completely different than my psychosocial assessment. My intake is very brief information that I obtain. And based on that, I decide if the practice could take them or not take them. And then I either assign it to one of my clinicians or I keep it. And based on me keeping that case, then I go more into the biopsychosocial. That's how I do it. Maybe somebody could explain how you guys do it.
Well, for me, my intake is usually about 15 minutes.
Uh-huh.
And like you said, it's just brief questions.
Okay.
But then I would like to have some of the information some of the questions that you talked about in the psychosocial, kind of like in my intake.
Okay.
So it's just a little more information about the client. And not only that, it's kind of like, right then and there, I'm saying, well, maybe I can't see this client because this client just told me that she has bipolar, like you said.
Yep.
So I think some of that information would really be good in my intake. So thank you for that.
Oh, absolutely. And I hope that answered your question. So it sounds like you guys do a 15-minute intake to kind of just assess if you want to continue to see this person. And then based on that, then when you meet them for your first session, then you do your biopsychosocial and you ask all this pertinent information. Is that how I'm understanding it?
Yes.
Absolutely.
Yeah. So yeah, so then this would be perfect for you to have a little bit to add to your intake, or you use what I gave you guys today as a tool for your own biopsychosocial assessment. Everybody does it differently. As long as you take some of the information and you create it into your own, as long as you get the information from your patient, and the objective is, can I help this person? Or does this person have greater needs and I can't do it? That's the whole objective here.
Okay. And just another question. How long does your psychosocial take? Does it take 2 sessions?
I do mine. So as I said, I focus primarily on children and adolescents. So my first intake is about an hour and I go through some of these, but I will put a little mark on something if I'm like, this needs to be elaborated on a little bit more, but I won't elaborate on it today because the way that she moved, it made her uncomfortable. And I'm going to say, so I see that that made you a little bit uncomfortable. We're going to tailor that for another time for when you feel a little bit more comfortable. So because I work with kids, after that first intake session with their parents and I have them alone, I'm a play therapist, I'm playing with them and I'm utilizing games and activity. And then I'm taking out my notes so I can go back to that question, because then their guard is a little bit lower, right? They're coming into this session, they don't know who we are, especially the adults too. They get a little worried, they get a little nervous. So by the second session, you ask them, how did that first session go? How did you feel? What was your interpretation of therapy? Can I answer anything? And then maybe you go back into one of your questions, because then by then they feel a little bit more comfortable with you.
Okay, I just have one more question. That's my last question. So what if this is, let's say your second visit, let's say your first visit with a client, and I know that I need more information. So I say, okay, I'm going to do a psychosocial. And then that client gets there and they have a problem.
What do you mean by
like they know why they asked for therapy today? They wanted to talk about their issues. So not so much, let me get your background information. This person came in wanting to talk. So what I find that I do, I might listen and see if I can help them with whatever they came in with. And then I kind of like plug in some of the questions here and there.
Yes.
Okay, so okay.
That's a great thing too, but don't forget, you are the clinician. You are driving this bus, right? We have an objective. If we do not drive the bus, our patients will go off on a tangent about who knows what sometimes, right? So it's important for us to bring them back. So today's session, we're going to be doing what's called an intake. I like to set up what I'm going to do from the jump. So during session, we're going to do what's called an intake. And an intake is a series of questions that I'm going to ask to kind of understand you a little bit more. Yes, you can talk about some of the things that you want to talk about, but I need to just ensure that I'm the proper and the right person to help you. So you see how you drove that? You drove.
I like that. Thank you.
Welcome.
Okay.
Any other question? Oh. Someone said, can you please give me general tips in doing assessments with elementary students? What do you mean? Besides a biopsychosocial?
Yes.
Okay. Can you give me something specific, like an assessment based on what? Anxiety, depression, or just in general?
In general, preferable or traumatic students.
Oh gosh. Can you put it in the chat? You were breaking up. Okay, trauma. Okay, something about trauma. Okay, so to tell you the truth, I would actually still do a biopsychosocial assessment with kids. This assessment that I utilize it with everyone. I just tailor it to the specific age range. I could send you some tips on what I have. I'll give it to Amira because I have plenty, because I'm also a play therapist. So I have plenty to share. And I'll give you a little listing of some of the things that I ask the kids, but with kids, it's different because we're playing with them. Kids are not going to sit across from you from the room and say, I've had trauma. They don't even know what that means. So they don't know what anxiety means. They don't know what depression means. It's your job to give them that information through your play and how to help them. But I'll definitely send some to Amira as well. Any other questions before we go? Anytime. Well, thank you for having me. This was informative, I hope. And you guys know where to find me. You can reach out to Amira and she can let me know if you guys need anything else. I'm also going to be doing the anxiety training. I'm also an anxiety specialist and pseudo neuroscientist. I wish I had the money so I could go back to school to be a neuroscientist, but I don't got no money. So the anxiety training that I'm going to be doing for you guys is going to be talking a lot about the neuroscience of anxiety and how anxiety is stored in the mind and in the brain. So hopefully you can join me for that. It'll be chock full of information that you can help your patients. I'm going to stop recording. Okay. Start video. Okay. All right. Well, thank you for having me, guys. Enjoy the rest of your Saturday and your weekend.
Thank you. Everybody have a good Labor Day weekend.
Yes,
Bye.
have a
Thank
good
you.
Labor Day weekend.
Thank you. Bye,
you.
everyone.
Thank you.
Bye.
Bye.
Thank you so much.
Anytime.